chronic groin pain, the pathoanatomical approach in the diagnosis of chronic groin pain will be better understood if you understand the anatomy and the functional anatomy of certain muscles which forms the groin region. So first and the foremost important muscle is the external oblique muscle, which has attachment to the ribs from 5th to 12th ribs. And these external oblique attachment fibers, especially the upper part, it interdigitates with the serratus anterior and forms a serrato-oblique complex. So these are the fibers of the external oblique, which forms external oblique aponeurosis and merges with the rectus sheath, thus forming the rectus sheath along with the aponeurosis of the internal oblique and the transversus abdominis. It has the distal fibers, it has attachment to the iliac crest, whereas the proximal fibers merges with the, so these proximal fibers, it has attachment after forming the aponeurosis, external oblique aponeurosis, merges with the rectus sheath, whereas the distal fibers, it has attachment to the iliac crest. And the fiber orientation differs between the proximal and the distal fibers. So distally, near the ASIS or near the ASIS to the pubic tubercle, the aponeurosis of the external oblique, it thickens to form the inguinal ligament. So this is the inguinal ligament, which extends from the ASIS to the pubic symphysis, which is nothing but the thickening of the external oblique aponeurosis. So the whitish appearance in front is the aponeurosis of the external oblique. Look at the fibers, it extends, it has attachment to the 5th to 12th ribs, whereas it interdigitates with the serratus anterior, that's the cadaveric portion, where the serratus anterior interdigitates with the upper part of the external oblique muscles. And those fibers are in similar orientation as that of the after the serratus anterior, whereas distally it is more obliquely downwards and it has external oblique aponeurosis too. So look at the orientation of the fibers, it varies between the proximal and the distal portion. So that forms the external oblique aponeurosis, merges with the rectus sheath. This aponeurosis forms the anterior layer above the umbilicus of the rectus sheath. Now that's the inguinal ligament, which extends from the ASIS to the pubic symphysis area, which is nothing but thickening of the aponeurosis of the external oblique, which is considered as inguinal ligament. And the most distal fibers, it has fleshy layers. So rather than forming the aponeurosis, it is directly attached to the iliac crest. So next is the internal oblique muscle, which has attachment to the thoracolumbar fascia with the lower 3 ribs. And the fiber orientation is exactly opposite to that of the external oblique. So it has major attachment from the thoracolumbar fascia to the lower 3 ribs, and also few fibers has attachment to the iliac crest. Again, this doesn't have direct attachment, it forms an internal oblique aponeurosis before it merges with the rectus sheath. So these internal oblique aponeurosis splits into 2 layers, envelops the rectus abdominis and thus forming the rectus sheath. So one goes in front of the rectus abdominis, the other one goes behind the rectus abdominis, forming the rectus sheath. So like external oblique aponeurosis, internal oblique aponeurosis also forms, and so the other attachment of the internal oblique, it has attachment to the lateral part of the inguinal ligament, which is formed by the external oblique, which is nothing but thickening of the external oblique aponeurosis. Also, it has attachment to the iliac crest, but the fiber orientation is exactly opposite to that of the external oblique, as we have mentioned earlier. So internal oblique has attachment to the lateral 2/3 of the inguinal ligament. It has attachment to the iliac crest. It has attachment to the thoracolumbar fascia. So now coming to the internal oblique cadaveric part, so it has the following attachments. It has attachment to the inguinal ligament, which is nothing but the thickening of the aponeurosis of the external oblique. It also has attachment to the iliac crest. It has attachment to the thoracolumbar fascia as well. And then they form the aponeurosis, internal oblique aponeurosis, and forms the rectus sheath. So this is the part where the internal oblique has attachment to the thoracolumbar fascia with that. Now here it has attachment to the iliac crest, and here the fiber has attachment to the inguinal ligament. And look at the difference in the orientation of the fibers. So the most proximal part is the one which is from the thoracolumbar fascia to the ribs, and then it forms the internal oblique aponeurosis, which splits and envelopes the rectus sheath and forms the anterior and the posterior part around surrounding the rectus abdominis. So this is the inguinal ligament, which extends from the anterior superior iliac spine to the pubic symphysis area, which is nothing but the thickening of the external oblique aponeurosis. So if you see here, the fascia lad of the thigh merges with the inguinal ligament. So it is difficult to demarcate the inguinal ligament on the distal aspect. So that's the fascia lata, which fused with the inguinal ligament. Inner aspect, if you see, so that is the inguinal ligament area, and the muscle which is behind it is the iliopsoas muscle with the associated sheath. The medial part of the inguinal ligament forms a triangular area called as the Lacrinal Ligament, which has attachment to the pubic area. So that's the pubic tubercle region where the Lacrinal Ligament attaches to it. And the lateral part offers attachment to the internal oblique as well as the transversus abdominis. So these are the muscular attachments offered by the inguinal ligament, especially to the transversus abdominis and the internal oblique muscles, especially their distal fibers. So just above the inguinal ligament, so this is the superficial inguinal ring, and inside, if you see, that's the deep inguinal ring. So the structure between the superficial and the deep inguinal ring forms the inguinal canal. So the following are the short external rotators. The first muscle is the piriformis, which attaches from the anterior aspect of the sacrum, and it gets attached to the greater trochanter medial aspect. So it traverses through the greater sciatic foramen and gets attached to the greater trochanter medial aspect in the upper part. So next muscle is the Obturator Externus, which extends from the obturator foramen, external part of the obturator foramen, and then it traverses under the neck of femur, and it has attachment just distal to the piriformis. So the next short rotator is the Obturator Internus, which has wider attachments to the ilium, to the ischiopubic ramus and the pubis, as well as the obturator foramen inner part, and it passes through the lesser sciatic foramen, and it takes a 90-degree turn from there, and it has attachment just below the internal obturator internus. So before it gets attached, it has slips from the superior and the inferior gamellae, and it gets attached to that, which has origin from the ischial area. So the next muscle is the Quadratus Femoris, which extends from the ischial part from this, and it extends and gets attached just below the gamellae inferior attachments, and it has attachment to the intertrochanteric line between the greater and the lesser trochanter. So this is the piriformis attachments from the anterior part of the sacrum to the greater trochanter superior aspect. passes through the greater sciatic foramen. Anteriorly, that's the right piriformis, which extends from the sacrum to the greater trochanter. Next, it is the Obliques Externus. It comes from the obturator foramen, outer part of the obturator foramen, and it has attachment near the greater trochanter, just below the piriformis. So this is the obturator internus muscle, which extends from the internal aspect of the obturator membrane and the iliac bone and the ischial region, inner part, and it traverses through the lesser sciatic foramen and gets attached to the greater trochanter region below the piriformis region, below the piriformis and the internal region. So before it gets attached to the greater trochanter region, it also has slips from the superior and the inferior gamellae and gets attached to that region along with the gamella. Now coming to the adductor muscles, adductor magnus, which has a wider attachments from the ischiopubic ramus to the linea aspera as well as to the adductor tubercle. So in between the attachments, it forms a adductor hiatus. So this is the linea aspera where the adductor magnus has attachments, and that's the adductor tubercle where there is a distal attachment of the adductor magnus. So between these two attachments, it forms a adductor hiatus. So next is the adductor longus and adductor brevis, which is present above the adductor magnus. So that's the adductor brevis, where the origin is from the body of the pubis. That's the adductor brevis, and the other attachment is the adductor longus attachment, and both has attachment to the linea aspera. So the proximal aspect is the adductor brevis attachments, whereas the distal aspect is the adductor longus attachment. So that's the adductor brevis and the longus, and the adductor longus is usually involved in the groin strain. That's the gracilis muscle, which has attachment to the pubis, and this is a short adductor pectineus, which attaches from the pecten pubis, pubic region, superior pubic rami, just below the lesser trochanter. So these are the attachments. So number one, it is the adductor magnus, which has a wider attachments to the linea aspera as well as to the adductor tubercle, and in between the attachments they form a adductor hiatus. The next one is the adductor brevis, which has attachment to the body of the pubis and to the proximal aspect of the linea aspera region. And this is the adductor longus, which has a distal attachment to the linea aspera, and it is attached close to the pubic symphysis near the body of the pubis. That's the pectineus, which is also a short adductor, which is attached to the superior pubic rami, and that's the gracilis, which is attached to the most medial aspect of the pubis and gets attached to the tibia.